I'm your host, Dale Sherbeck, and welcome to the HQ podcast. For those tuning in for the first time, the HQ is a podcast serial produced by CHA Learning and is your trusted source for important conversations on healthcare issues and topics from those that are leading and impacting the health system. Together, we'll explore these topics as we continue to learn together. CHA Learning is the professional development division of Healthcare Can and is uniquely Canada's only national fully online learning provider serving all of healthcare. So please check out more about our learning programs and services after this episode and discover how we collaborate with health leaders and organizations like those we feature on the HQ to empower healthcare professionals with the knowledge, skills, and relationships to impact health system improvement. Thank you, listeners, for joining me today for another important conversation. The issues of workplace violence and workforce safety have quickly become among the most important topics we're having in healthcare today. While the issue of violence is not a new phenomena, the fact that almost every healthcare organization is talking about it today and seeking strategies and solutions to address it does seem to suggest we're at a watershed moment. Enough is enough and things have to change. All regions of our country have some form of legislation that provides workers, including healthcare workers, protections that include the right to a safe workplace that is free from violence and other hazards. However, in healthcare, where so many have followed their calling and entered into the sector to help those most in need, it is hard to contemplate refusing work that might present a risk when doing so would come at the cost of providing the care they are there to deliver. In some industries, like mining, there is a safety-first culture. Safety is not a continuum, but rather an expectation that ends in zero harm. When I have this conversation with other leaders, however, there is almost a pause, almost a calculation of how to balance safety with the duty to provide care in the complex, adaptive, and challenging environment that is healthcare. While many hazards can be identified and managed, there is an inherent unpredictability to healthcare due to the nature of disease, the unpredictability of life, and the variability presented in a sector that is all about people who themselves can be unpredictable, especially under stress. But does that mean that healthcare workplaces aren't and shouldn't be safe? That is a question I have struggled with in preparing for today's conversation. Add to that context the fact that our current health system has been horribly stressed by our preceding pandemic and that, as the CMA writes, has exposed significant vulnerabilities in our health system, particularly regarding health workforce safety. And as the CMA continues, unsafe working environments are contributing to high levels of burnout and driving many healthcare workers to leave their professions. This not only deters new entrants, but also exacerbates staff shortages, increasing the costs associated with recruitment, training, and turnover, all of which jeopardize the well-being of healthcare workers, and I might add, all Canadians alike. It is sentiments and positions like this which are increasingly leading to united voices calling for action and change to foster safer healthcare workplaces and protect both those that work in these spaces and those that are served in these spaces. To help us through what is clearly a very complex topic interwoven with many connected threads, I'm delighted to be joined by Myfanwy Marshall, Vice President, People and Experience at the Centre of Addiction and Mental Health, or CAMH as it's known to many. Myfanwy is a strategic leader with expertise in designing and executing transformation, enriching employee engagement and experience, and ensuring effective delivery of support to employees and leaders within dynamic and complex operating environments in both private and public sectors. Myfanwy has been at CAMH for over 8 years and previously serving in the roles of Interim Vice President, People and Experience, Director of People and Legal Counsel, Senior Manager of Human Resources and Labor Relations, and Manager of Labor Relations. Prior to joining CAMH, Myfanwy worked extensively in labor relations in large organizations including CN Railway, the Toronto Star, and the Liquor Control Board of Ontario. Myfanwy is a labor and employment lawyer by training and proudly holds the Certified Human Resources Professional designation. She is also a committed volunteer in the community, having served on the boards of directors of the Fred Victor Centre and Dixon Hall. So hi, Myfanwy, and welcome to the HQ.
Hi, Dale. Thank you. Thanks for having me.
It's great to have you again here today. So thank you. To have, I know, which is going to be I think it's going to be a very interesting conversation, one which is, I think, being held by many people across the country. And so maybe as a place to start on a topic which is very hot and very topical, and given your own bio and career, Wondering if we can begin with why does it seem to be a different conversation in healthcare than, say, in the railway industry and other industries across the country?
Yeah, thanks for that. I think you touched on it in your opening. I think that the biggest difference is in the essence of different of the industries. Healthcare is a people business. It's about looking after people. It's about making people's health better, their outcomes better. And so I think that dealing with people day in, day out who are often ill, some of them at a very dark place in their life, like struggling with terminal diseases or very significant health issues of variety, it creates a really different dynamic and a different dynamic in the context of the work environment. And so I think that's the significant difference. Railway industry is not immune, or transportation generally, from workplace violence. But I think a lot of their safety, I would say their larger safety issues, are related to a lot of the physical environment in which they're in. You're operating trains that are over a kilometer long that are carrying dangerous goods that are
Hmm.
incredibly dangerous if not operated correctly, or if there's a malfunction. So it's just a different nature of the experience. And I think in healthcare, we're caring for people, and that, like, people come in all shapes, sizes, and in all kind of presentations. So that, I think, is the significant difference with the discussion. And I think this discussion, as you've mentioned, has been growing. So I think that's been growing more in healthcare than in other sectors.
So, why is it so much more difficult, do you think, to address this topic or even to talk about it in healthcare?
I think it's kind of probably a number of factors. I mean, I think healthcare workers, I think, are here for because they have a calling and they want
Hmm.
to help people. And so I think part of that, in essence, is that historically, perhaps, and I haven't done any kind of academic study on this, I'm sort of conscious of that as an academic hospital, but I think that there's a culture of underreporting, or people saying, well, the patient's sick. That's why it happened. The family was upset. So I think there's a reluctance to blame the patient if that is the source of the violence, or cast blame to others. In part just by the nature of people who are here and why they're here. I also think that uh, it's been underreported for a long time, and so I wonder if the conversation is growing now, because people are just, to your point, I think you said enough is enough, and we need to talk about it more so that we can collectively find solutions.
Yeah, it's because we've had other conversations on the podcast as well about, the need for compassion or more compassion in healthcare
Mhm.
as an example, right? But it does seem like even in your comments there that compassion, stands at odds, right, with, you know, being, saying that something bad has happened, I guess. And so so there's a predisposition, I guess, to excusing it almost.
Yeah, I mean, it's almost like the empathy is about two sides of the coin, and sometimes you've just had enough and you don't
Mhm.
want to accept it. And I think on the flip side, yeah, people are just wanting to help. And I think, the general public, I think, cares about healthcare workers. People come to hospitals, to their GPs, to whatever healthcare institutes they're going to, because they need help, because they need treatment, and they inherently feel that's probably going to be a safe space. And so I think to hear what's happening when it's publicized in the news or wherever else is shocking for people. And so I think people do care about it, and that's why the conversation is getting more attention as well.
Yeah, that makes sense. So when we talk about violence in the workplace, it's a word I think that we can all relate to. But
Mhm.
when you really break it down, like what are we talking about? I mean, can you put a definition on it about what it includes or doesn't include, perhaps?
I don't know if I could have a crisp definition, but in terms of what it includes, it's physical as well as verbal, or verbal, I would say. So, like, from a physical perspective, it can be hitting, it can be punching, it can be biting, it can be spitting, it can be a host of physical altercations or attacks on people. It can be attempts to harm somebody with something, with something they're potentially a weapon. I think it also, though, it is around verbal abuse. And if you talk to healthcare workers, and unfortunately, some patients and some families are, the way they speak to people is just really shocking, with verbal abuse, with racial abuse, with slurs, with shouting, with just it's a long, long list. So I would include that in the violence because I think equally it has an impact on people's well-being to the same extent as a physical attack. So I think it's both those things and not just what some people might think of as just physical.
Yeah, I think that's an important distinction, and I suspect, I mean, not that, I mean, maybe you have more data on that, and maybe we can talk about data in general, um, but that those, those examples of incivility or microaggressions or verbal abuse perhaps are even fewer reported. Yeah,
I think they are.
and they're the greater number of the injuries that people are exposed to.
Yeah, I mean, we definitely do get reporting at CAMH on those issues, but I think I mean, I can't prove it, but I would say it's definitely underreported because again, I think people are either they can't be bothered, they're like, oh, this patient does that all the time. Or again, they feel like, well, they're sick, they're having a bad day, we'll just ignore it. So I think there's definitely an underreporting on the verbal related violence. Hard to actually capture how much.
So we've talked a little bit about, and you've said, referencing my point about enough's enough, but do you think there's been something that's happened, like why are we talking about this right now? Like why has it become so much more prevalent in the last 12 months? Has something changed or is anything different?
There's been like one event that's changed it. I think from certainly if I think about hospitals, I think we're asking questions more about it. I think we're actually reaching out more. And, it's hard to say what's motivated the questions is that more staff have been percolating, coming forward. But definitely at CAMH, we've had a long priority on workplace violence. And so, as I'm sure many hospitals have, and so we are trying to get also more data on it because I
Hmm.
think as much as data doesn't solve the problem, it informs what kind of solutions you can build. So I think asking the questions has certainly increased it. And then I think also, there's more studies on it. You see, there's more reporting across in various agencies across Canada. The Ministry of Labor here in Ontario has usually a healthcare sector initiative this year for 25-26, it is around workplace violence. Like year before it was on musculoskeletal injuries, which again, common injury in healthcare. But I think there's more people coordinating and talking about it together. I know from my colleagues in the Toronto region where we meet regularly, we talk about it quite regularly as well. So I think that's increased it. So it's data, it's about more conversation, asking the questions. I also do think that part of it is there's a lot of societal factors that I think are impacting on just whether it's incivility or violence generally that are outside of healthcare. And so I think that's having people be more reflective of where else are they seeing violence. And so that maybe again, haven't done a study, but I think that could also be raising the conversation.
Yeah, I think there's probably a lot of things, like even, there's, I would say like the last decade, as we've had a lot of attention focused on psychological safety, right, and
Yes.
training and things like that. And so whether that's perhaps equipped people with more a voice, perhaps to speak up, or so does it speak
Yeah.
to that there is more reporting on the issue, or is there more incidents, or both?
Again, it's hard to tell. Definitely, I think there's more reporting. And so by virtue of the reporting, I feel like it's happening more often. But again, was it underreported before?
Hmm.
Um, I think from the readings I've done, there's suggestions that yeah, it's increased in volume as well as reporting. So it's not one or the other. But again, it's sort of hard because you don't have strong data earlier to compare it to. But I think maybe it is to your point around psychological safety, whether staff are feeling more comfortable to raise that, and I hope they are. So that could be fostering again that increase in reporting is the focus that's happened on creating cultures where there is space for people to come forward on things that are uncomfortable to talk about.
Yeah, I would agree. So, I mean, it's a bit of a, a leading question, but, what is the role of reporting in addressing this issue?
I mean, I think it's incredibly important, and I don't want to diminish sort of the impact on people's well-being by being subject to violence. But I think without the data, it's very hard to figure out what solutions might have an impact and measure whether it is having an impact. So I think it'll help us prevent violence, but also mitigate violence. We want a workplace that has zero tolerance for violence and ideally zero violence. We realistically cannot guarantee zero violence. So we want to look at how can we prevent it, how can we mitigate it when it happens, and how can we support staff who have been unfortunately victims of it. And so I think that data helps us look at where are we best to focus our energies and where will we support the staff the best. So whether that's looking at care plan or treatment plans, whether it's looking at points where patients may get agitated. Is it in transfer of units? Is it from discharge? Is it on admission? Looking at what our staffing is. Was there high sick time on the shift when the violent incident occurred? Were there
Hmm.
things that we maybe could have addressed differently? So I think looking at all of those things, where the patient population is at the time. Is it happening more on weekends or evenings when maybe there's less staff around or less other supports around, or less activities for patients? And so, like, we have a lot of patients who are longer term, and so if that they have less to do, what happens if they are becoming agitated, and how can we support? What initiatives can we introduce to address that? So I think the data helps us think about where we can intervene. And then I think also, like, reporting is pretty important just on a day-to-day basis. So we have, for example, a daily safety call, which every day we get together for about 10 to 15 minutes with our predominantly directors across the operational and clinical roles, and just identify any risks or safety issues that we've had in the last 24 hours or we anticipate coming up. And that includes talking about what's our staffing looking like. Are we going to be okay over the weekend? Are we going to be okay for the night? Do we have, is security got enough staff on? And just identifying all of those areas where the acuity of the patients is high in a particular unit, so that others in the organization are aware of where they may be called in to help, and also that the directors, maybe who have units specifically that are potentially at risk, can have some support in how to address it before something happens. So I think there's the data helps inform all of that, and reporting helps inform it.
Yeah, definitely. So a great business case in terms of the importance of data, in terms of
Yeah,
how we do improvement and learn, and
yeah.
incident management and all the rest of it. So thank you. Um, so how does context change some of what we're talking about here in Myfanwy? Like, is it different? That you know CAMH is located where you are, that you're serving the populations that you're dealing with, versus a rural community hospital, or another kind of uh, organization that is perhaps delivering to a different population.
Yeah, obviously, that workplace violence is an issue for all hospitals, so it's not unique to CAMH. And as I said before, I think people are coming to CAMH when they are at a very low state. We treat people who are acutely ill, and so that can have. I think when anybody is acutely ill, you can have behavioral issues that arise that are not related to their illness, but just a side effect, if I can put it that way.
Hmm.
And so I think the context, I don't know that it shows up that differently, like much like other hospitals. Violence is either from patients or families, and unfortunately, sometimes staff on staff. I think that's fairly the case for whether it's a rural hospital or a downtown urban hospital. Um, so I think it's an issue that we all have to address. And I know at CAMH, like, one of the things we have put in place is some trauma informed de-escalation training,
Hmm.
which is really focused on trying to address potential problems before they become problems. And so working as a team, collectively as a group, as to how can you support a patient who may be starting to have behavioral issues around aggression. And similarly, it would apply to families as well. And that's sort of a formal training that we have. We also have some initiatives around This Is Me, which is an initiative to get to know the patients so that when they are here, you can actually use the information you have to help connect with the patient and potentially de-escalate them or prevent them from escalating. Because, you can talk to them, or, they really don't like country music in the background. And so if the radio's on in
Yep.
the nursing station, turn it off, like some simple things, but that can be very powerful in impact. So I think the context, I think violence shows up pretty much similarly, I would think, in most hospitals. So I don't know that the context is overly different. We might just have different, certainly we're a larger hospital than many rural hospitals. So we probably have larger volumes in terms of incidents, unfortunately.
Sure. That makes sense. Thank you. So, um, do you have a sense in terms of, I guess, any of the other system drivers that may be sort of continuing to lead to the violence that, is happening? It's like are there other things within the system that maybe are contributing to this?
Yeah, I think there are for sure. I would say I would highlight sort of two that I think are major ones. I think funding and resourcing of hospitals
Mm-hmm.
is one. And then I think social determinants of health. So, I mean, the funding, basically, the growing need for healthcare across Canada, like it's not a diminishing need. We have an aging population, which requires more healthcare. Certainly from CAMH perspective, mental health services are needed more than ever. And that certainly was highlighted through the pandemic. But that puts pressure on the system. You hear lots of stories about hallway medicine. That's people who aren't in bed. So if you are just had a heart attack and you're lying in a hallway, your behaviors, et cetera, could be problematic because you're suffering.
Yep.
So I think all of that funding and resourcing of hospitals has an impact. And I also think on the social determinants of health, like, this is part of our CAMH's strategic plan, or our mission is, like, housing is health and employment is health and family supports and community is health. Because if you don't have those things, your physical and your mental health is likely to be impacted. People who have to live on the streets are going to have physical health issues because they can't feed, they don't have enough funds to feed themselves. They don't have safe housing. They have no employment or precarious employment. So all of those things, I think, are factors that increase it. And I think it impacts on violence in the workplace and healthcare. I'm sure it impacts in other areas of public service as well.
Yeah, makes sense. So, I mean, you've got a population that is itself more stressed. Um,
Exactly.
you have
Yeah.
a population that is arriving at your facilities in greater levels of acuity,
Hmm.
and perhaps in greater numbers.
Yeah.
And yes, and if policymakers were ever wondering when we talked about the Grey Tsunami and what it was going to do to our healthcare system, this is probably a
Yeah.
good example of what we
Part
were
of it.
talking about.
Yeah.
Yes.
Yeah, unfortunately it is. And I think, I mean, I'm a labor and employment lawyer by background. I think the first cases I ever addressed in workplace violence actually related to long-term care homes, which was shocking to me. But people are stressed while they're there, and unfortunately, things can arise. So, yeah, I think it's definitely a problematic that we don't have enough funding and resources in the system. And I think the impact of what the economy is doing is particularly acute now for a lot of people. A lot of people are in very desperate positions. You hear more and more about layoffs that are happening, and so how are people going to feed their family? How are they going to keep their housing? So all of those, I think, are contributors.
Yeah, and it becomes a very slippery slope, right? As we face economic situations like this, it's going to put more pressure on our healthcare
Yeah,
facilities, who are themselves being asked to reduce and cut back, and it's
yeah.
like it's not a win-win situation by any means.
No, it's definitely not.
Um, so you know that question I was sort of struggling with in my intro, Myfanwy, about preparing for this conversation, um, about whether healthcare is inherently less safe than other industries, and if so, does it need to be so? Right? What can we do to change that? Do we have to accept that there are some hazards that are part of this job, these roles? Like if you're a firefighter, you're going to deal with fire. Fire's dangerous. Or rather, are these kinds of narratives perhaps getting in our way of sort of accepting? I think even to your earlier comments about the beginning about making excuses for why it shows up in our workplace or your workplace, and uh, whether some of these hazards like violence directed at workers shouldn't, we should have a zero tolerance sort of approach to some of these things. So I guess, is it a question about safe or safer? Is it something that we can frame differently, and in terms of, really, say that healthcare should be like mining or railway or any other industry like that? Where do we take this? I mean, what are your thoughts on that? Or can you help me even to unpack that a little bit more?
I would say I don't agree that healthcare is an inherently unsafe industry. I think and I would preface that to sort of say, I think all industries, like there's nowhere that has 100% safety all the time. My house doesn't have 100% safety. I don't have 100% safety if I go for a walk in the park. So I'm not saying that that means that there can't be incidents that happen or violence in the workplace, but I just don't think that it's unsafe as a premise. I also, sort of on the flip side though, is I also don't think that we should accept or do accept that it's violence is a hazard like fire that we have to expect to deal with. I think that I'd like to say we could have 100% no violence. I don't think that's realistic because it's not something like organizations, leaders can have 100% control over, but we certainly can take a lot of steps on prevention and on education and how we respond when there has unfortunately been an incident. So I think we should be striving towards a violence-free workplace, but we know that from the experience of healthcare workers that there have been incidents, and we also have to support employees when they happen. So I think a focus around prevention strategies is very important. And then, I mean, I would also just point out, like other industries are certainly challenged by violence and also by safety issues. Like in terms of hazards in the workplace, I was, looking at some information to prepare for this. In 2022, looking at some Ontario data from WSIB and the Ministry of Labor, construction and transportation were at the highest in a hazard perspective. In regards to critical injuries, the industrial sector was leading there. Healthcare was in the top four, but it wasn't the leading cause. So I think, again, I don't say that to diminish the fact that there is violence, but I think we have to accept that there are things we can do to help, and then we can mitigate and prevent some violence, and that we should be focusing on doing more, and then how to support staff when we're not able to succeed that zero tolerance. Because at the end of the day, like mining, I mean, they've certainly had terrible injuries and incidents that often is what promotes or is the burning platform to start safety cultures. But I think so mining, like this idea of zero tolerance isn't really 100% possible here, because as a public hospital, certainly the Ontario Public Hospital Act, we have an obligation to treat people, and we don't have the right to say to someone, I'm sorry, you're not behaving, you'll have to leave and get healthcare elsewhere. So it's very different from retail or transportation or other industries where you can actually say, we choose not to serve you because you are not meeting our standards of behavior.
Mm-hmm.
And so we have to balance that with how we manage violence. But again, it's not to condone violence. It's just saying we don't have the right to turn people away. And so we do have to think creatively as how we can prevent, what strategies we can put in place, and how we can support the staff when those strategies haven't been successful.
Thank you, Myfanwy. I know it's a difficult question, but I appreciate you walking us through it, and I think it helps provide other context. So building on some of your conversations, and you've mentioned that your trauma informed de-escalation strategies. What are some of the other things, or maybe even you want to deal with that or talk about that in more detail in terms of some of the work that CAMH is doing to prevent violence and protect staff?
Yeah, I'd love to highlight some of that work. So I do want to highlight our trauma-informed de-escalation for safety and self-protection is our TIDES program. And that has been, I mean, we take a really, I think, a continuous improvement approach towards safety and both workplace violence, but all safety here at CAMH. And TIDES is a prime example. So that's training that, as I say, it works on training teams as to how to address behaviors that could be escalated, whether that's agitation or aggression. And that's sort of evolved over time and expanded over time, so that now we have Tides champions who are, working on the floor and that are available to either coach people, to remind people about de-escalation techniques, or to step in when they're needed as well. If, for example, we had newer staff who haven't needed to use them yet. And so we have different iterations of that to keep it enhancing it and improving it for our staff. We've also we've partnered with UHN, for example, and we're providing that training to that hospital. So it's not just specific to a mental health hospital, but is applicable to acute hospitals of all kinds. And we in fact have like a customer service version, so that people, whether that be like your registration staff or
Mm-hmm.
staff within a hospital or externally, we've done lots of training for non-healthcare sectors that's around this de-escalation. So that's one thing that we're quite proud of, and the team that does it is outstanding. And we believe that it is having an impact to improve our workplace. We have a workplace violence prevention committee, which is a joint committee between union and management. So that's actually co-chaired by myself and our chief executive nurse. As well as having our union leaders and worker representations and managers on it. And so that committee focuses, it has different work plans. Currently, we're just working on our work plan for the next 12 months or so, with 3 areas of focus, one of which is around reporting, and some is on some support and training for staff. It started a number of years back. It was sort of kicked off initially by the CEO. So there's been a strong commitment to it for a long time at CAMH. And, originally or several years ago, we started off with risk assessments for 3 units that were seeing a higher increase in incidents. And so we did risk assessments from those units. And then we spent time through the committee in implementing recommendations. So we're sort of auditing things as we go along, and looking for areas to improve. We developed, again, jointly with our unions, a Lead the Way to Safety, which is a supervisor leadership training. And again, that came out of the Workplace Violence Committee and our Joint Health and Safety Committee. We've done physical audits of the workplace. We have a number of safety protocols, which we're constantly reassessing. We do our workplace risk assessments. And we also, as I say, we partner quite strongly with our unions in a lot of this work. So those are sort of the top of mind things that we're working on. And we certainly have, we have patient and family counsel. So we speak to patients and families, about what they're experiencing. Because again, that can help inform how are we addressing and supporting patients, but also can be a platform in which we can share information as to how our staff are experiencing things.
Well, it's highly commendable, and you're doing a lot. And I think clearly, I think leading the way in many respects. So thank you for sharing. So from the perspective of leadership, or leaders, I guess, within a healthcare organization, what is their role and behaviors to be able to better promote, safety and wellness?
I think one of the roles is definitely listening to staff and really believing them too, because as I say, there has been, I think, a culture of not reporting or acceptance. And I think we need to create spaces where staff feel comfortable to come and share what's their experience, and that we are believing them and supporting them, not only in that moment, but going forward. So I think that's a big role for leaders. I think showing up, being there to support staff who've had difficult times, taking time to follow up with staff, I think is a role for leaders. And I think, not only talking to our staff about what initiatives we may be doing or working with them or sharing in town halls, but showing it to them with actions. So ensuring that we're following up, that we do town halls, we'll talk about initiatives that we're kicking off, but making sure we do follow up to staff to say, here's what this is the stage we're at. Here's what we've accomplished. Here's the next thing that's happening. And as we go forward, we to the extent we have been more focused on data, sharing some of that information as well from a data perspective. We've certainly, as leaders, we actually identified workplace violence in our quality improvement plan. So that's been one of our indicators that we've been working on for a few years. And so we report back not only to our board, but to our staff as well in our reports on the quality improvement.
Wow.
And then ultimately, we do really want to work with staff, or be clear with staff that workplace violence is not okay. I'm not saying it doesn't happen, but they need to know that because it happens doesn't mean we condone it, and we want to find ways that we can prevent it and mitigate it happening less and less in our workplace.
Yeah, so that speaks to the zero tolerance, I guess.
Yeah.
Still, you're taking that approach, and yeah. So when it happens, you're managing it, but you don't want it, and you would like to get
Yeah.
to zero.
Yeah.
So
Yeah.
yeah,
And I mean, we do like where it is, for example, if it was in relation to a patient, and it appears to be an ongoing issue, we have very detailed conversations at the clinical tables about, is that patient, should they stay in that unit? Should they be moved? How can we, what do we do with their assessments to ensure that we are capturing behavior earlier, so that it doesn't escalate, or should they be in a seclusion, or other mechanisms? So we work as well to see how can we improve the patients, because I don't think the patients want to be, I don't think patients are going in thinking I want to hurt a healthcare worker. So we want to support them to the extent we can, but we need to focus on our staff.
yeah, for sure. Yeah, I would agree that people are acting out of fear or some other kinds of pain or suffering in many
Yeah.
respects. I'm sure. Um, So you mentioned, I think, your collaboration with your unions as part of one of the things that you're doing, and I know from your other work, this is an area of your labor relations, obviously, is a strong area for
Yeah.
yourself. So maybe you could sort of talk about your perspective or your philosophy in terms of how employers and unions need to or can or collaborate in this space together.
Yeah, I mean, I think I've always been of the view that this is it's obviously such an important topic, but it's like we have the same interests. We want the same outcome. We want our staff to go home the same way they came to us, safe and healthy. And so it's a common interest. And so working together with them, I think not only results in better outcomes for the staff, uh, it also improves your labor relations, which can have positive impacts elsewhere.
Hmm.
And I think, our union leadership and our union reps, they are healthcare workers. None of them have come from some other industry and just plopped into working as bargain unit president or a union rep. So they know the reality of what is going on the floor, and they've lived it. So I think they also bring that perspective, and they have an important role, certainly just as union reps, in protecting people's rights. So I think it's a good reminder for us to make sure that we are following all the rules. Not that we don't, but I think it's always good. So I think there's like just so many advantages to working together, and certainly, it shows the staff that we're serious. That we are serious and that we are listening to them, and that we're not interested in positioning with the union. We want to find solutions that are win-wins here for them.
Well, that's again really great to hear, and in terms of your work and your leadership in that space, because I think for some organizations it probably does become a bit more of an adversarial conversation.
Yeah, it can be, and it can, and obviously unions have a role to play, and some union reps present themselves differently than the others, same as leaders within hospitals do. And so, yeah, that can be. But I think as leaders in the organization, we need to sort of invite unions to the table to try and find solutions here. I mean, we even work with our unions. We have a lot of redevelopment that's been going on at CAMH for a number of years. We're in our final phase, and we've talked to them about the building design, because we've taken input into safety features in the buildings, like making sure the hallways are, not narrow or don't have hidden spaces, that the doors are accessible, that there's mirrors, etc. And certainly the unions, because they've worked in the units, they've worked in the environment, have valuable input in that.
Great. Well, that's a great example of working together and sharing your knowledge and experience for a common goal. So speaking of common goals, for national organizations like Healthcare Can, and our capacity to serve as a trusted advisor with our members, yourselves, CAMH, who want to work jointly on this issue, what would be your guidance to us or your ask?
I think one of the things I would say is keep the conversation going. I think we had our session back in June. It was very beneficial for people to talk about their experiences. So connecting different healthcare providers together so that they can share their experience, brainstorm solutions together, I think is a forum. It's a different forum. So I think that's helpful. I think it also keeping it front and center with funders. So advocacy work, I think is maybe an ask. And then I would say also like facilitating or supporting research and standardized data collection. Different hospitals of varying sizes have different abilities around data collection. And I think the more we can all compare apples to apples is going to be helpful to really get a full picture and also to advocate ourselves to our funders or to others who might be able to support us in improving our workplace violence prevention.
Thank you. It's good advice. So as we come to an end here, Myfanwy, any final words for our listeners?
I certainly really appreciate the opportunity to come and talk about this issue. I really care deeply about our staff, and think about this a lot as to how do we protect them, and then when we haven't been successful in preventing violence, how do we really support them to ensure that this has the least impact that it could on them, and that they're able to return to work and prosper here. So I think I would just say we have to keep talking about it. We should try and think about what can we do jointly, and we should be sharing what we're doing with each other, because again, I think people have lots of things on their to-do list. They have lots of priorities across hospitals and initiatives going on. And so if we can share that information, I think that's really positive. I think it's better for the healthcare industry, and I think it's better for Canadians.
Thank you. Well, I think that you as an example and the work of CAMH in general on this issue, I think, should give us a lot of hope in terms of, what is possible in terms of building a culture of safety within a healthcare organization. And I really think you are leading for many and doing tremendous work. So I thank you for sharing so much of that with our listeners here today and helping us to better understand this issue so that we can work together on creating a safe environment across all of Canada.
Yeah, thank you, Dale. I appreciate it.
Okay, talk to you soon.
You too.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.